3, 2, 1. So we are live. Over to you, ma'am.
Good evening, respected delegates and dignitaries. We welcome you to today's academic rendezvous. We at Lupin are deeply in gratitude for your persistent service towards your patients in such tough times. Lupin has always led the path to many digital, first of its kind, new initiatives with the purpose of nurturing medical science. Today, we are all gathered here for the launch of Indian Pharma's first ebook on the Amazon global platform. I would now invite our Senior Vice President, Mr. Brajendra Singh, to share a few words with our delegates. Over to you.
Thank you, Varuna. Very good evening, all. Good evening, doctors. And I hope you and all your loved ones are very safe and taking the necessary precautions in the fight against COVID. And we at Lupin salute your selfless efforts to protecting the society and keeping us safe during this unprecedented era or unprecedented time which we are passing through in the COVID-19. In these days, scenario of particularly if you look at the diabetes has become a global pandemic, and at the same time associating with the COVID and the diabetes is further worsening the condition of diabetes. As per the estimate, there will be 642 million patients will be there by 2040 of the diabetes globally. And the prevalence is very high in middle and low income countries as compared to high income countries. At the same time, this all complications of diabetes leading to kidney failure, leading to heart attack, leading to lower limb amputation, and there are lots of complications. So with this objective of providing the Indian clinical perspective of managing diabetes and its complication, on the first issue of the series focuses on CV complications in diabetes. Keeping this in mind, the menace of diabetes, we proudly associate with all the 19 contributors of this first issue, along with the Jaypee. The title of the book is Complication of Diabetes Mellitus, Bad to Bench. And this book is edited by the renowned endocrinologist, Dr. Manoj Chadha from India, and the foreword is written by Dr. Marc, Marc from UK. So I'm sure this will help many clinicians to have a better care for a diabetic patient and better outcome. And I'm very hopeful this is going to be a very meaningful, knowledgeable book for all the clinicians. So with this, we have with us our President India Business, Mr. Rajiv Sibbal. So I request Sibbal sir to have their thoughts and their words. Over to you, sir.
Thank you, Vijender. So good evening, respected doctors. Trust you and your dear ones are safe and taking all the necessary precautions to fight COVID-19 pandemic. Today, entire world salutes your noble effort and relentless dedication in battling this pandemic and shielding the society. Team Lupin is parallelly working shoulder to shoulder, keeping in mind our greatest integral value of giving back to society. Every Lupinite today has ensured consistent continuity by ensuring uninterrupted supply of medicine to the patient and utmost safety of those who are working as frontline warriors in the pandemic fighting against all the odds. India, a home to 77 million diabetics, represent the second highest population in the world. In India, the doctor population per thousand is much lower as compared to other countries and also as per the WHO norms. It is necessary to focus on multidimensional approaches and promote prevention activities. And so, Lupin has always taken pride in being associated with the cause of diabetes-free India, for which it has always partnered with esteemed physicians like you. Lupin has also been at the forefront of fostering scientific outlook and advancing academic awareness, so it really values the academic partnership with Jaypee publication for enriching the skills of the clinician based on the Indian perspective. Through this partnership, Lupin is extremely excited to launch the first ebook in pharma industry titled Complication of Diabetes Mellitus Bench to Bedside. The book is authored by 19 academicians across the country, edited by the renowned endocrinologist, diabetologist, Dr. Manoj Chadha, foreword by Dr. Marc, and shall be distributed through Amazon platform globally. The objective of this book is to provide insights into clinical expertise on diabetes and cardiovascular complication considering Indian perspective, along with global update, based on real-world evidence and experience. This collaborative academic initiative with Jaypee is designed to enrich knowledge of doctors for better patient outcome, enabling enhanced understanding of the complications of living with diabetes and empowering effective individualized management of the patient. It's my pleasure to welcome you all for this ebook launch on the global Amazon platform. My heartfelt compliments and best wishes to all the academicians who are part of this academic journey. Before I conclude, I would like to thank you all as you continue to treat your patients during these testing times. So once again, thanking you for joining this particular program. Now I would like to invite Dr. Bhargav to share his insights on this academic endeavor.
Thank you,
Dr.
sir.
Bhargav.
Thank you, sir. Very good evening to all of you, and thank you for being here. It's kind of a historic and a momentous occasion when, for the first time, an ebook is being launched in this manner. And the relevance has already been highlighted by Mr. Brijendra Singh and Mr. Rajiv Sibbal. I'd just like to share a couple of slides with you to illustrate the rationale why Lupin has undertaken this initiative and what is the importance of the experience, as Mr. Rajiv Sibbal had mentioned, that this is all about expertise and the role of expertise in clinical practice. So there's just going to be 2 slides. I'll not take up much time of yours, but it'll set the ball rolling and the tempo for also the discussion that will happen subsequently. So this is what I call the professional lifespan. And it's applicable to doctors, but it's applicable to, every professional. We have all been students, we have acquired knowledge, we have become professionals, we have practiced, we have become successful, and some of you have become hyper successful. And you have gone on to gain exceptional clinical experiences, by virtue of which some of you are proclaimed as experts, as Dr. Manoj Chadha here and Dr. Marc, who I will introduce subsequently. So there is a need for experts to share their exceptional clinical experiences, and not just share, but share globally. And that is what this ebook, which is going to be available on Amazon, is going to facilitate. This is not just about Indian experience being distributed in India. It is the Indian success stories being distributed around the world so that these experiences can be validated and adopted if applicable in the respective practices. The reason why clinical experience is not a bad word anymore, I know we are in a world of evidence-based medicine and so on and so forth, but clinical trials, while they will remain the gold standard for validating any drug, device, or therapy, what have you, but they have their limitations. Like, for instance, sometimes for a particular molecule, there will be no evidence, incomplete evidence, or conflicting evidence. Also, the limitations in applicability of group results to an individual patient are sitting across the table from me. I cannot tell him you have a 79% chance of being taken care of. He's just going to change the doctors and go elsewhere. So percentages are fine in RCTs, but they don't apply in practice. It's either you treat or you don't treat. You're either successful or you're not successful. Also, you have these great landmark trials where the results are published in, they're declared in conferences, people stand up and applaud. That's all great, fantastic. 3,000 patients followed up for 5 years, 79% efficacy, great. That is reason to applaud. But 79% efficacy means 21% failure. Why did that happen? The drug does not have a bias. It's going to do the same thing in every patient, but some patients do not respond. The key lies in picking the appropriate patient for that molecule. And that is something that is not written in RCTs. That is not mentioned in the inclusion-exclusion criteria. It's not mentioned in guidelines. Speaking of guidelines, guidelines are only guides. They're not definitive. They're not situational. They will not tell me how to customize therapy in a particular patient. So clinical practice, which is what healthcare is all about. It is not about RCTs and guidelines. It is about clinical practice. And clinical practice is beyond RCTs and guidelines. And while it has to be within the framework of the guidelines, but it has to be customized and situational also. So this is a beautiful article by Professor Snyderman from Mayo Clinic, which I recommend everyone to go through. While these are all the data elements that you see on the screen, which we rely on to evaluate a therapy and to decide whether to adopt it or not, but that is not enough. What is also required is mechanistic reasoning, which we know from physiology, pathology, and so on. But more importantly, what is not available in the public domain is clinical experience. That is something very intrinsic and individualistic to every clinician. And that also forms a significant part of the decision-making process. And this entire gamut is known as clinical reasoning. And that is what the world is now moving towards. It's no longer a blind following of RCTs, it is clinical reasoning. So in short, clinical practice is all about a lot of these things: clinical trials, guidelines, XYZ, non-medical reasons for picking a molecule, we all know that, plus mechanistic reasoning, and most important, clinical experience. There is no way that clinical experience gets disseminated. At the most, it will get disseminated in group discussions and conferences, but that's about it. So in order to facilitate that the pearls of these clinical experiences and success stories, this book has been put forth with all the case-based presentations and discussions. And this is what Dr. Manoj Chadha has made it into a reality, and what Dr. Marc Evans is also here to discuss and highlight. So with that, I will briefly, in short, introduce our esteemed faculty. In true Indian tradition, where Atithi Devo Bhavo, let me introduce Professor Marc Evans first. He's from Llandough Hospital and the University Hospital of Wales College of Medicine, Cardiff, UK. He's a consultant diabetologist, and previously he was a lecturer in diabetes and endocrinology at the University of Wales. Dr. Evans' research and clinical interest include health outcomes in patients with type 2 diabetes mellitus and the health economics of diabetes care, something that very few people focus on. And I think that is a very significant, important part in the therapy of any disease. Dr. Evans has published extensively. He has more than 200 articles, several book chapters, abstracts to date. And he's particularly known for the studies that he has participated in and written about on vildagliptin, the DPP-4 inhibitor. He has also served as an investigator on numerous clinical and laboratory-based studies, and is currently also the editor-in-chief of the Journal of Diabetes Therapy. Dr. Manoj Chadha, our Indian stalwart, very well known in the Indian circles and international circles. He is MD Medicine and DM Endocrinology from State GS Medical College and Mumbai University. He's consultant endocrinologist at PD Hinduja Hospital and Medical Research Center, Mumbai, and Hope and Care Center, Vashi, Navi Mumbai. He's also trained at University of Ulm, Germany, in the use of artificial pancreas. That is the expertise that very few of us have. He's also the immediate past president of Indian Society of Bone Mineral Research and past president Endocrine Society of India. And he has also been conferred with the fellowship of Indian College of Physicians and the Royal College of Physicians of Ireland. So with that, I would like to hand over to Dr. Manoj Chadha for his address. Sir, all yours.
Thank you, Dr. Bhargav, for your kind words of introduction. And a warm welcome to Professor Evans from India. And we are grateful that he's agreed to spend some time with us and share his pearls of knowledge. And I also like to thank the Lupin team, Mr. Sibal, Mr. Singh, and Ms. Barnona for having involved me in this project. It was a great experience. As Dr. Bhargav said, very often in India, we keep talking about, I feel it is like this. And there was a time when they used to laugh at us saying that, what is I feel? But probably now the evidence-based medicine with what we say as experience-based medicine coming together. So the EBM remains there, but evidence and experience equals to then clinical practice. And I just got 2 or 3 slides to share with you. Okay, great. So this is what we, very often keep talking about, the huge number of diabetic patients. And we are very much aware in terms of the prevalence and the incidence. So the incidence referring to the number of new cases that come up every year. And whenever IDF has tried to project what will happen in, say, a decade or 15 years from now, every time that I have been following them, say the last 25 years, they have turned out to be wrong, because we always reach those targets much before the date they had predicted. I guess there's nothing to be proud about it, because the way one of my colleagues says that if all the Indian doctors of all the pathies got together and started treating diabetes, we still don't have enough doctors to treat the diabetic patients. So that is why the importance of trying to control this epidemic of diabetes, the importance of training every level of doctor. And now we are looking at the paramedical workers, the nurse educators, the diabetes educators, and whosoever is interested, because I'm seeing so many clinics now being sort of assisted by their own patients, especially the type 1 diabetic patients, because that gives them a chance to look around and see what is happening in terms of diabetes. And it also gives them a chance to sort of earn their living and be useful to society. So that's something that is good that is happening in India and probably in other parts of the world also. So we know that data is something which is lacking in our country. It has just started in the last 1 decade. If you see the publications from the Indian scientists, it's been a great change from what it was, say, a decade earlier. And I'm hoping that with the younger generation getting more active, we'll have more epidemiological data from India. We'll have more data on the complications. Traditionally, we've been taught that Indians have a higher risk of these non-communicable diseases, the cardiovascular disease, atherosclerotic CVD, diabetes, whatnot. And the fact is that even the complications, the microvascular complications, the macrovascular complications, they tend to come up about a decade or 1.5 decades earlier than what the Westerners talk about. But this is all not in print. It is more of hearsay, more of experience. Fortunately, this is changing. And I think in the next few years, you're going to have very good epidemiological data coming out from India. And that, will be the framework for the healthcare workers, how to go about, modifying the healthcare policies in our country. What the exercise that we have gone through, and very grateful to all the contributors to this publication, is try to put some thoughts in terms of Indian data, in terms of Indian guidelines. And as Dr. Bhargav said, guidelines are meant to guide. So they are more of a guidance. So if it comes from your local health worker, it becomes much easier to follow than if it comes from the Europe or the American scientists. So this is what the attempt has been with this book. And I hope that this is a beginning, and we'll have such editions coming up in future also. So the current book has been divided into 5 chapters, and we have looked at the epidemiological data that is available from India. We have tried to look at the standard complications of acute myocardial infarction, cerebrovascular accident, the progressive decline in renal function, the diabetic kidney disease, some discussion on diabetic cardiomyopathy, and what are the current available measures which have really changed, I would say, in the last 2 years. I think it was in 2015-16 when we started hearing about the SGLT2 inhibitors in the market. And then the EMPA-REG came out for the first time, saying that not only was it neutral, but it was actually protective, helpful reduced 3-point MACE, it reduced mortality, which was something unheard of ever since this EVO outcome trial started. Last 2 years, things have even sort of sped up. We are hearing about improvement or preservation of the renal function. We are hearing more and more about decrease in hospitalization for heart failure, improving left ventricular function, both with diastolic dysfunction, systolic dysfunction, and whatnot. And in the 2020, in the last few months, SGLT2 inhibitors have been shown to be useful not only in diabetics, but also in non-diabetics. So probably the next 2-3 years are going to be very exciting in terms of management of diabetes, cardiac disease, renal disease, and all three put together. So with these few words, I think I've set the stage where we're going to look at our esteemed international speaker who's going to tell us how things are in terms of management of cardiorenal complications on the Western Hemisphere of the world. And I'm really grateful once again to my co-contributors, to the Lupin Pharmaceutical for helping us to be in contact with the Jaypee publishers, who I think have sort of run against time and brought out this lovely publication. I'll thank you very much for this patient hearing, and probably we look forward to some discussion after this. So with this, I'll request Dr. Bhargav to again take over.
Okay. Can I request Dr. Marc Evans to address us for the few minutes before we get on to the panel discussion? Good afternoon, sir. Once again, all yours.
Good afternoon, everybody. So it's a great pleasure to be with you here. Once again, I would just like to extend my great pleasure to be a part of what I think is an exciting project. I think Lupin Pharmaceuticals are world leaders in the digital medical education field. And really, it's an honor to be involved and invited to be part of what I think is a cutting edge area, and what is an area that is going to grow in terms of importance over the coming years. And I think the COVID-19 pandemic has just been one of those occasions whereby the need for such innovation as this has become really apparent. So if I may just share my screen with you, then I will be hopefully able to get my presentation. Can you see my slides? Yeah?
No,
Yes.
sir.
Yes, we can.
Okay, so I've got about put together a few thoughts on some of the issues.
Sir, sorry to interrupt. We are not currently seeing your slide. It is some other window. Can you unshare and reshare the screen, sir?
Yeah, okay, there we go. Okay, let's start again.
Yeah, Outlook was visible, but not the slide.
Can you see now?
Yeah, that's right. Perfect.
Right, perfect, right, okay. So
Yes,
I
sir,
just
okay.
Yeah, so I just thought I'd put together a few quick slides just to reflect the need that we have in terms of this particular publication. So as we know, cardiovascular disease and kidney disease are indeed the major cause of morbidity and mortality in type 2 diabetes, with atherosclerotic cardiovascular disease, heart failure, and kidney disease really being the three biggest contributors to morbidity, mortality, and also cost associated with the condition. And one person dies as a result of diabetes every 8 seconds, largely as a function of these factors. Heart failure is particularly pertinent, with about 14% of people presenting with heart failure as the earliest manifestation of their cardiovascular disease. Kidney disease is extremely expensive and is the most costly individual complication of type 2 diabetes. Heart failure is actually also extremely prevalent. 2/3 of people with type 2 diabetes of 5 years duration or longer will have evidence of cardiac dysfunction. And 50% or more of people with type 2 diabetes will in fact die from cardiovascular disease. And this is a significant impact with respect to life expectancy. Looking at somebody with diabetes without established cardiovascular disease, then there is a 6-year life expectancy loss with the onset of cardiovascular disease. Comparing somebody with diabetes with cardiovascular disease to somebody without diabetes or cardiovascular disease, then there's a massive 12 years loss of life expectancy. Therefore, understanding approaches to minimize the risk of cardiovascular disease, heart failure, and kidney disease, and implementing this on a locality basis is, I think, an imperative to optimal treatment of type 2 diabetes, which is why initiatives such as this ebook, focusing on the evidence, focusing on the data, focusing on strategies to improve patient outcomes is very important from the individual practicing clinician perspective, but also very much so from the perspective of the patient. So this is why an initiative such as this, supported by Lupin, I think is so valuable, because it is contributing to improving the quality of life and the quantity of life of so many people with diabetes. Talked about kidney disease. Kidney disease is also extremely a common condition. Accounts for about 50% of the type 2 diabetes disease burden, and half of people with kidney disease globally have diabetes. And as a consequence, diabetes is the most common cause of progression to end-stage kidney disease. Not only is diabetes a major cause of mortality related to kidney disease, it also significantly increases the morbidity. This is some population-based data from the NHANES cohort. If you have type 2 diabetes alone, compared to not having diabetes, then what this relates to is about a 4% increase in mortality risk. If you have albuminuria as a measure of kidney disease, there is a 17% excess risk of death. If you have declining renal function, then there's about a 24% increased mortality risk. And if you have a combination of both, then the excess mortality compared to somebody without diabetes or kidney disease is in the region of 47%. And this is all driven by cardiovascular disease. So therefore, approaches to reduce the burden of these complications is incredibly important. And this is reflected by international consensus statements, by guideline pathways, whereby the management of cardiovascular disease remains the primary treatment target in our treatment strategies for people with type 2 diabetes. And what they talk about is the fact that the arrival of new agents with a plethora of new evidence has triggered a paradigm shift in the way in which we treat people with type 2 diabetes, beyond simply thinking about glucose control. And that's where educational activities such as this become so important, because we need to be aware of what these therapy strategies are and what exactly does the evidence show us and how we can put this into practice. And the reason that we need such education is that there is a vast amount of evidence and literature available. And this started, as our esteemed earlier speaker said, back in about 2015 with the results of the EMPA-REG study showing that empagliflozin reduced cardiovascular mortality, all-cause mortality, and improved heart failure outcomes. Subsequently to this, there have been many studies with both the GLP-1 receptor agonists and other SGLT2 inhibitors demonstrating benefit in terms of both cardiovascular outcomes, renal outcomes, and heart failure outcomes. In terms of the SGLT2 inhibitors, they really have stimulated a vast amount of interest in terms of clinical science over the last few years or so. And some of this may be driven by this mechanism of tubuloglomerular feedback, whereby reducing glucose and sodium reabsorption at the proximal part of the convoluted tubule translates into a glycosuria and natriuresis, and thus results in a reduction in activity of the renin-angiotensin system related to increased sodium delivery to the macular densa. This effect has an impact in terms of glomerular function, translating into glomerular afferent arteriolar vasoconstriction and efferent vasodilatation. thereby potentially protecting the kidney and also translating into cardiovascular protective outcomes. And indeed, when we look at the data with these studies, we'll see here that the SGLT2 inhibitors as a class have been associated with heart failure outcomes, renal protective effects, which we shall touch upon in a moment, but empagliflozin reduced cardiovascular death, while the GLP-1 receptor agonists have reduced the burden of atherosclerotic cardiovascular disease. But what I think is apparent when we just look at slides like this is the multitude of data that exists and evidence that's out there. And what we really need is a guide practically on how we use this data to improve our patient outcomes. And this takes me back to the Lupin support for this innovative ebook to help translate evidence into practice and practice into outcome benefits. And of course, this is what guidelines are all about. There is a need to incorporate these agents into the management of people with type 2 diabetes to optimize outcomes. This is a guideline decision pathway statement. But how do we do that? How best do we make the choices, and how do we use the evidence to inform our choices? And that's really why activities such as this and other activities that I and my colleagues have been involved with Lupin are in fact so important to the healthcare community. And we see data such as this. This is a two-dimensional representation of the association between cardiovascular and heart failure hospitalization outcomes, demonstrating the utility of the SGLT2 inhibitors from the combination perspective of CV and heart failure endpoints, with evidence supporting, as we've already touched upon, the MACE cardiovascular benefits of the GLP-1 receptor agonists. Just thinking about cardiovascular death, empagliflozin, 38% reduction in CV death, with the only other diabetes agent to have been shown to produce CV death beyond the benefits already discussed in terms of metabolic control being liraglutide. And it's important to recognize that these benefits are in excess of any metabolic control outcome benefits, as the studies from which these data are derived are set in the context of risk factor and glycemic equipoise. And we can see just how quickly the Kaplan-Meier curves separate with empagliflozin in this particular study. When we go on to look at kidney outcomes, what we see here with a broad composite kidney outcome, including GFR, progression to end-stage kidney disease, renovascular death, and albuminuria, is evidence of benefit for caromelina with linagliptin, the DPP4 inhibitor, with the GLP-1 receptor agonists, and also with the SGLT2 inhibitors. But if we take away the albuminuria component and focus just on hard kidney outcomes, such as declining GFR, end-stage kidney disease, renal or cardiovascular death, then the benefit persists only with the SGLT2 inhibitors. So just looking at this data, there's already an apparent complexity that we need clarification around in terms of the literature, the science, and how to put this into practice. And when we start to look at this relationship, for example, between kidney outcomes and albuminuria, we see that the evidence of hard renal outcomes really is in the context of the SGLT2 inhibitors, with albuminuria benefit being present with both the SGLT2 inhibitors and the GLP-1 receptor agonists. So this is great data, and it's great for me to talk about these data, but how do we put this into practice to make a difference for our patients? And that is where activities such as this become so important. We have guidelines. We have a multitude of guidelines. This is the ADA EASD consensus statement, talking about the need to incorporate evidence-based therapies such as the GLP-1 receptor agonists or the SGLT2 inhibitors into people at high risk to mitigate the burden of disease complications. And the fact that these treatments should be used independently of level of glucose control to produce these benefits. When we look at cardiology guidelines, class 1A evidence is conferred to the SGLT2 inhibitors in terms of heart failure and CV benefit, to empagliflozin from the perspective of CV death, to the GLP-1 receptor agonists from the perspective of atherosclerotic cardiovascular outcomes, and to liraglutide from the perspective of cardiovascular death. In terms of heart failure and CKD. Class 1A evidence, the best evidence that you can have, is related to the role of the SGLT2 inhibitors. When it comes to heart failure hospitalization, Class 1A evidence really pertains to the burden of reduced heart failure risk with the SGLT2 inhibitors. Not only do we have this now in type 2 diabetes, but we have growing evidence outside of type 2 diabetes with the EMPEROR reduced and the DAPA-HF studies extending the label indication of these agents into the non-diabetic cohort of people with heart failure. Similarly, from the perspective of renal disease management, we have consensus position statements around the use of an SGLT2 inhibitor in people with suboptimal glucose control from the perspective of managing glycemia, as well as providing nephro and cardio protection, but also in those who have achieved glucose control. The European Association for Renal Dialysis and Transplantation would have us switch in an SGLT2 inhibitor, replacing other non-evidence-based agents to provide renal and cardio protection. So there is, again, a challenge in how we do this. And this is why educational activities in support of such guidelines and the complexity that such guidelines may represent is so important. We have the K-to-go treatment algorithm for patients with type 2 diabetes and CKD, talking about what threshold of GFR should we be considering initiation of different therapies therein, and how we should approach the management of kidney disease risk management in people with type 2 diabetes, the threshold of evidence base for an SGLT2 inhibitor at a GFR of 30, but there is growing evidence for benefit well below this GFR for the SGLT2 inhibitors. And again, educational activity to share our knowledge, to share our experience and best practice is extremely important to deliver the best outcomes and optimize our patient endpoints. ESC guidelines, again, more guidelines just to share with you. And this is around management of diabetes in terms of preventing kidney disease progression, with class 1A evidence given to renal disease monitoring, tight glycemic control, good blood pressure control, role of an ACE inhibitor, and also the role of SGLT2 inhibition. So clearly, what we now have is an evolution of glucose-lowering therapies in the context of extensive CV safety studies to demonstrate that there are very many different drugs that, beyond their glucose-lowering effects, particularly in terms of things like the SGLT2 inhibitors and the GLP-1 receptor agonists, that have benefits in terms of cardio, renal, and metabolic endpoints. And there are ongoing studies with both the SGLT2 inhibitors and indeed the GLP-1 receptor agonists outside the arena of type 2 diabetes, focusing on the potential benefits in other disease areas like heart failure, like kidney disease, in people without diabetes. So undoubtedly, there is more than ever a need for medical education to help our understanding of how we best position and use these agents to optimize our patient outcomes. And that's why I think an activity such as this is so important, it's so timely, and why I, as a diabetes specialist, am so honored and very happy to be involved both now and going forward with Lupin in these innovative, cutting-edge educational activities. So with that, I'll hand back to our esteemed chair and partake in the brief discussion we have planned.
Thank you very much, Dr. Evans. That was very enlightening and very succinctly put. Dr. Manoj Chadha and Dr. Marc Evans would now join in a panel discussion. And fortunately, I think we have a very attentive audience. They've already posted some questions. So why don't I take the question of the audience? The question is, metformin is strictly contraindicated at what level of GFR? Would you like to flag off, Dr. Manoj Chadha?
Okay. So I think with all the evidence, with all the new drugs, metformin still remains our primary drug, unless it is really not tolerated or we are talking of contraindications. So in terms of contraindications, currently, I think most of the guidelines say that if the GFR is more than 45 ml per minute. So one of the, I think, issues in India is that we are still depending a lot on serum creatinine value. So we have to move towards looking at eGFR.
Absolutely.
And if the eGFR is more than 45 ml per minute, there is no issues. You can continue with whatever dose you want to use of metformin, maximum being 2 grams of metformin per day. At 30 ml probably, so 30 to 45, please don't start or don't increase the dose of metformin. The current dose can be continued. The problem, I think, is less than 30 ml per minute. And probably most guidelines or most clinicians would say not to use it below 30 ml per minute. Having said that, if I were to stick my neck out a little, it's not that metformin hurts the kidney. Let's understand, it's not that metformin is a nephrotoxic drug. It's that traditionally we've been taught that metformin metabolites accumulate and they can cause acidosis and things like that. But I think we'll get a word in from Dr. Evans also, what he feels, whether he's seen lactic acidosis in his 3 or 4 decades of practice. You have to be very careful below 30. I have used it because I'm fortunate I work with some good nephrologists. So I have their backing. And in our diabetes kidney clinic, we do some experiments. But for practical purposes, in a public meeting below 30, you better not use it.
Sure, that's absolutely the politically correct and the medically correct thing to say. Dr. Marc Evans, would you like to add to that? Would you agree?
That's very succinctly put, and I couldn't have put it better myself. You're absolutely right. A GFR of 30 is a threshold below which we would discontinue metformin, largely on the basis of a perceived increased risk of metabolic acidosis. And in answer to your question, I've very rarely seen a case of metabolic acidosis. And where I have, both of which, I've only seen 2 cases, occurred in the context of an intercurrent illness with associated hypoxia, both in the setting of pneumonias. So actually, from the safety perspective, yes, we wouldn't continue below 30. And I think that makes perfect sense. The other thing to remember is that a lot of patients will have transient illnesses that will drop their GFR to below 30. So I think it is important to bear in mind things like sick day rules. So when somebody has an intercurrent illness, I think you should discontinue or sort of postpone the use of the metformin, but reintroduce it once the intercurrent illness and the GFR has resolved. And I think that's true for things like SGLT2 inhibitors, ACE inhibitors, and non-steroidals.
Perfect. Okay, that in fact that before we go on to the book, let me just get back to Dr. Abhishek Rada, who asked this question, and he has also put in another question as a trailing. So about the GFR, Dr. Rana, I'm sure you have figured out after the reply of our esteemed panel. Now, also keep in mind the replies that have been given, they bear out the fact that you cannot have a guideline recommendation for something like this. You have to customize your therapy when you're monitoring the patient. As Dr. Marc said, if there is an intercurrent illness, which may not have been there in the RCT or the guideline that is writing their recommendations, but you have a patient with that intercurrent illness, then you have to use your own discretion to take care of that. That is what clinical reasoning is all about. I think this classically exemplifies the mechanistic reasoning, understanding what is happening in that one patient. And what do I do? Do I stop a drug? Do I not increase the drug? Do I change the drug? Do I stop the drug intermittently and resume it later? So these are all matters of clinical experience and decisions that need to be taken. So coming to the book, I was pretty excited when I saw the theme. And what I would like to ask you is that we have touched upon cardio-renal complications. do you have any plans of going beyond that and taking on, things like neuropathy and retinopathy and NAFLD and, the other things that diabetics get plagued with? Dr. Manoj Chadha.
Yeah, I think we've touched on the major complication, micro and macro, in terms of cardiovascular disease, which also includes the renal part. Yeah, but you're right. We have not gone into neuropathy, and now NAFLD is a huge problem. I think diabetologists are more excited than the hepatologists, and we are looking at a couple of drugs which are into phase 3. So beyond the standard, drugs that we've been using, we'll have something more. So there is food for thought for looking at the other complications in diabetes. I think the important part is to get people sensitized, the physicians sensitized that it is not HbA1c or fasting glucose or postprandial glucose. We need to look at the blood pressure, the albuminuria, the liver enzymes, etc. Those are the things that we have to look in the future.
Right. Right.
And preferably the nearer future than the distant future.
Correct. So that's great. I think that will give us an opportunity to come out with a second edition also.
Yeah, I mean, I think that's a great idea. I think a second edition of this would be really timely. As Dr. Manoj said, there are a variety of new therapies being trialed. We published a systematic literature review just this week, in fact, in diabetes, obesity, and metabolism, looking at the potential role beyond glycemia of the SGLT2 inhibitors and GLP-1 receptor agonists in non-alcoholic fatty liver disease. And I think, to the point that was made earlier on around, clinical experience is really important in terms of implementing evidence, implementing guidelines. And one of the areas that a book like this can help with is it can help supplement clinical experience with, because a lot of the content is case-based. So it can help illustrate and supplement and support the experiential nature of clinical practice. In the second volume, focusing on complications, microvasculopathy, retinopathy, those sort of factors, I think it would be really important, really timely, and very, very welcome by both the diabetes and wider healthcare professional community.
In terms of managing complications, I mean, typically, books in the past have always focused on how to treat a complication.
Yeah.
Now, as you mentioned, I mean, both Dr. Chadha and Dr. Marc, you mentioned in your talks about the newer molecules that have been coming up for the last 3 to 5 years, which have enabled us to defer or prevent altogether the complications. So should that also not become a focus for, all the primary care physicians too?
Yes, I think this is a really important area in terms of managing diabetes and helping healthcare professionals that aren't necessarily specialists in the field understand the data, understand how to implement the data on an individualized patient basis is extremely important. And that's where activities such as this book, I think, are so valuable and so helpful in that they can be used by an everyday practitioner to inform his or her practice and bring up their level of expertise in a sort of experiential, evidence-based fashion with a view of implementing these guidelines in a way that is evidence-based and can support improved outcomes for the patients, preventing complications, delaying complications, reducing morbidity and mortality, and also providing a cost benefit. Let's not underestimate the importance of better treatment of diabetes from a health economic and from a societal perspective. So these sort of educational activities have very, very many implications in terms of health, in terms of patients, in terms of economics, in terms of wider society.
Right. Dr. Manoj Chadha, your views on this?
No, I think he's mentioned it, he put it very, very clearly. My only point is that we are still lagging so much, not only in terms of treatment or using the latest medication, but in understanding the outcomes. Once our physicians are family practitioners, you should remember that the 80% of the care is not by physicians or endocrinologists, it's by the family practitioners. So that is why, the level of writing has to be in such a way that it's understood. There's no idea just giving all the trials without, explaining what is really required or how we can put it into our day-to-day practice. So that's, I think, the very good beginning that has been made. Education, which is going to lead to better outcomes.
Well, you make such a great point. There was a very famous quote by Tony Blair here in the UK many years ago. What was his plan to success? It was education, 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 and I think that's very true in terms of healthcare delivery. We talked very briefly about the SGLT2 inhibitors, and I touched upon some of the wealth of data in my very brief presentation. Despite all of that data and all of the evidence that has accumulated since 2015, if we look at real world data prescribing activity in Europe, only about 15% of patients who would gain benefit are actually receiving an SGLT2 inhibitor. So you can clearly see the need for appropriate education around disseminating the evidence and trying to help people implement this in terms of clinical practice.
Right. No, that's absolutely true. I think it takes a very long time for any new therapy to get absorbed the way it should be.
Yeah.
I mean, in heart failure, we have these ARNIs. I mean, till date, there are only 25% of the heart failure patients, who should be getting ARNI are getting ARNI. And it's the same with SGLT2, as you rightly mentioned. I think your replies have stimulated a lot of audience response. We are getting some questions. If you don't mind, I'll just pick on a couple of them. Okay, this is a fairly old one, but I guess it's old wine in a new bottle. Can prolonged use of sulfonylurea lead to pancreatic exhaustion in type 2 diabetes mellitus and lead to absolute use of insulin and OHA is becoming ineffective?
Well, okay, so the answer to that is probably not. That's the current thinking is that, yes, the sulfonylureas don't necessarily exhaust the islet cell, but what is required is that for a sulfonylurea to work, you need to have functioning beta cells. And the natural history of type 2 diabetes is a decline in beta cell function. So I think that is, that's fundamentally what happens. And in essence, that's why you see the declining functionality of a sulfonylurea in type 2 diabetes.
Right. Dr. Manoj,
I think, going back to the education perspective, one of the things that I think would, that we should be doing, and I think we are going to try to do this with the support of Lupin, is to talk about diabetes post-COVID. Because increasingly now we are seeing people presenting with previously well-controlled type 2 diabetes or no history of diabetes, presenting with insulinopenic features following 3 to 6 months after a COVID infection, because SARS-CoV-2 and the little proboscis bit on it has the potential to injure the islet cell and particularly cause insulinopenia. And people will present with diabetes who are extremely insulin resistant and indeed ketoacidotic. So understanding what COVID-19 might mean to diabetes management now, but also in the coming years, I think is an important educational activity to make people aware of the fact that people may be presenting with ketoacidosis as a late manifestation of previous COVID-19.
Perfect.
Yeah, I think basically we have to remember sulfonylureas have been around for 4 decades. Wonderful experience. And now I think all the bad things that have been said about it have been, sort of erased. But this is a very valid point. Beta cell dysfunction, declining function. So you can't go on flogging the dying horse. That old statement with 4 decades ago applies very much. So you realize insulinopenia, please get on to the next line of drugs, whether it's insulin or whatever other things you want to use.
Okay, and now the clock tells me that it's the time for the highlight of the evening, the launch of the book that we have all been waiting for. So I'd like to hand over to Dr. Manoj Chadha to do the honors. Sir, all yours.
Okay, thank you very much, Dr. Bhargav. And all our contributors, thank you once again. We have come up with something very interesting. I hope it's the beginning of our association. And as Lupin, dignitaries, and Professor Evans has mentioned, we should look for further discussion on complications. And we need to go on to this. Where do we get the link?
Sir, we would request you, if you can hold the book and unveil the book. I would request Sir Brajendra sir.
I'm there with the book, but
So,
thank you so much, sir. So thank you to all the academicians who've been a part of this academic endeavor. And I'm sure it's been a very exciting journey for each one of us who's been associated with this. And I request Dr. Manoj Chadha, sir, to, if you can go to the link, sir.
Should we go to the launch video first or the link below?
Sir, the launch video.
So that's how it's going to be visible to the world?
Yes, sir. And you also have an Amazon link there. So the Kindle version is also uploaded and it's available now.
Oh, great. So it's gone international.
Yes,
so
it's gone international,
the first, book on Amazon globally.
Yes, sir. And it's a first initiative in the Indian pharma industry. And we are really thankful to all the clinicians for this, sir. And especially to Dr. Manoj Chadha and Dr. Marc Evans for taking out their time from the busy schedule in carving out this.
Banuna, are we see something now?
Yes, sir. Vishal, can you please help me with the technical support?
No, I'll play the video then from here.
Yes, sir.
Should I share, sir?
Yes, please. Please share, Vishal. Yes, Vishal.
Okay, sir.
Please share. Vishal, can you please go on to the Amazon link?
Yes, ma'am.
So the book is already uploaded, sir, and ready to be downloaded. So this is the Kindle version of the book.
Yes.
You can click this.
Yeah, you can click on this.
I think great. This is available now.
Right.
Very good. So congratulations.
Congratulations. Yes.
Very good.
It's good to see the book on our favorite store, Amazon. Hopefully it will become a household object, just as much as a household object as everything else on Amazon.
Yes.
Absolutely, sir.
Thank you so much.
Thank you.
So on this note, we thank our eminent academicians for their contributions who have authored the book, and we are glad to be a part of their academic journey. We are honored to have our Honorable Editor-in-Chief, Dr. Manoj Chadha, sir, and foreword written by our guest of honor, Dr. Marc Evans. We are grateful to them who have spared their time from their busy schedule to share their clinical insights and clinical experience through this book. We thank Jaypee, our publishing partner, for their association with this first of its new initiative of hosting an ebook on the Amazon global platform. We thank our delegates and dignitaries for their gracious presence on this exciting launch of the ebook. And above all, we thank our team members of Lupin, Sinox team members, without whose support this academic feat wouldn't have been possible. Thank you, delegates and dignitaries, for making this experience an enriching one. Thank you very much. Thank you all.
Thank you. Thank you, Manoj.
Thank you.
Thank you.
Thank you.
Bye-bye.
Thank you, sir. Bye-bye.
Thank you very much.
Thank you, sir. Thank you,
Thank
Dr.
you.
Manoj. Thank you, Dr. Marc. Thank you, Dr. Bhargav. Thank you,
Thanks,
sir.
Dr. Chadha. Thanks, Dr. Marc. Thank you, everyone.
Thank you, Dr. Marc. Thank you,
Thank
Sibbal,
you.
sir. Thank you, Dr. Manoj Chadha, sir.
Bye.
Thank you, sir. Bye-bye.
Bye-bye.
Thank you all. We are ending the streaming now.